This is the final presentation, Implementing Telemedicine at Happy Health. I'm Chris March for Ashford University, MHA 616, Healthcare Management and Information Systems, under Professor Lazar, and this was completed October 19th of 2019. Happy Health. Well, Happy Health is an isolated rural hospital. It's about 160 beds. It serves a community of about 80,000 people that is mainly farming community. The problem with Happy Health, because it's rural, it's unable to recruit physicians to cover 24 hours a day the services that are needed in the hospital. Mainly what falls short is intensive care, a lot of mental health, and some radiology reads that need to be done to get definitive diagnoses on patients so care is not delayed. The lack of services creates also unnecessary transfers to other hospitals that are expensive, long trips over the mountain or flights, a longer length of stay, simply because things aren't being diagnosed and treated right away. Patients end up getting treated later and they don't get the care that's needed. Delays in care. The care that's required is being delayed because diagnoses aren't made, and or mental health patients are being admitted to beds because there's no mental health services to provide the care to give them medicines to turn them around and send them out to the community again, or get them into programs via whatever means, telehealth or within the community. So there's really no easy follow-up to care. The board recommended that we use telemedicine, so we put a program together here right now to explain why telemedicine. So telemedicine is going to hopefully bridge the gap. It's going to provide patients much needed access to care that they are not receiving in the hospital currently with the lack of physicians. It's also inexpensive as an alternative compared to an in-house doctor because the services are only on call. So when you call them, then they get a service fee, but it's not like you're retain them 24 hours a day and the hospital is paying for that one doctor. We obviously want to have a reasonable cost to integrate the services, and it definitely must be secure. And because we already have a very nice electronic health record at Happy Health, we wanted to integrate into that as well through our IT. Implementation must overcome barriers to support, meaning there has to be a way of implementing this process so that everybody can give feedback and everybody buys in, and then the ease of use is there, or so the quality can be there. Considerations in telemedicine implementation. Well, we did a software development lifecycle review, and we looked at how the software would carry us forward into with our current EHR system and implement into our IT system. And we found that a company called VMed has a very nice platform that would integrate into our current system that we use. And we did a risk analysis working with VMed surrounding security, and it seems to be the most streamlined system out there, considering what we would like to pay and what we also want to receive for our patients, and what can we use it for in the future. So we want it to meet the needs of the end user. So whether it's the provider that is going to be seeing our patients, or it's our staff or physicians that are seeking the provider, this has to be easy for them to use. Obviously, the patients need to feel comfortable using it and feel like it's not cumbersome as well. The cost of the package, we don't want to pay an exorbitant amount of money for something that we're not going to be able to use. So through VMed, we were able to establish a cost with some very familiar devices, which we'll talk about in a minute. Licensing of providers is handled through VMed. Malpractice insurance of the providers also handled through VMed. It's a package deal. So the state licensing is all taken care of. And then the cost of training to use the telemedicine platform, we've really developed a lot of continuing education around this. And we also got some from VMed and from some other vendors that have already utilized this and used their best practice guidelines to do this. But through CE time, and we're able to implement this so that it comes at a small cost to the hospital as far as productivity and staffing. And really, the system is easy to use. You use the devices that you already are familiar with in an iOS platform or an Android platform, and it's very familiar to the staff. And most people, those are the types of devices that they use anyway. So it's very, very familiar, and it's not scary. Well, we want to see quality improvement through telemedicine implementation. First of all, we have to understand why the implementation is necessary. We're not meeting the needs of the community that we serve. We cannot provide the access that they need to get definitive diagnoses, to get mental health care, and or to get care in getting off the ventilator settings, intensive care in the ICU. We want to make sure that we have all these services for our patients. We want to roll out in one area, obviously, to make sure that it works. So our plan is to roll it out in the ICU with an intensivist group. We have mental health, radiology, and the intensivist all set up and ready to go. But we want to start in one area, make sure it works, and we get the feedback from staff, from change management, and project management, so that we can get all this implemented, any changes that need to be done, so that it works and everybody feels comfortable with its use moving forward. So overcoming those barriers by addressing feedback. And we're going to measure that success through improved access. That improved access is going to be through our patients in the ICU or that aren't receiving the care right now. And then furthermore, going into the emergency room with our mental health patients and these patients that are getting admitted waiting a diagnosis or a surgery or something like that with the radiology read. So it's all going to be measurable success. And then obviously, again, the bottom line is improved care at a good cost to the community that we serve. We want to make sure that the system is secure. So we currently have at Happy Health a multi-factor authentication for the access to our email and our platform when you're outside the hospital. It has been very, very successful. We haven't any data breaches. Patient information is vetted through the multi-factor authentication, and we're going to use this with the company VMed. As a matter of fact, VMed insisted that we use something like this to make sure that our stuff is secure, and they suggested it as well. So the integration and the system that we use can be used with VMed, and it's going to work out nicely. It is a specialized hardware. It sends a one-time authentication password to the user, and it's very easy for the user to use because they're already familiar with the software or their phone or the iPad or whatever the integration or the devices that they're going to be using. And it's also easy for the provider to use. It's you do it once, it's real easy to do it again. It's not like it gets confusing. It's pretty darn easy. And it also maintains the confidentiality of all of our patient data. And that is the biggest thing. When we're sharing data across platforms, we want to make sure that we are HIPAA compliant and that we go forward and do things the right way. The telemedicine devices. Well, VMed has some devices. Mainly, it's an iOS platform or an Android platform. The iOS I'm familiar with. I used iOS. We rolled out the iOS platform in a trial group, peer group, with a change manager, and we got some staff. And we got some physicians, both our older physicians and our younger physicians together. And they felt that they were very comfortable to use. They gave us some feedback. But the most important things are they're familiar devices. They're security enabled through multi-factor authentication. They're low cost. They cost about $500 a pop. There's a stand they can go on that makes them mobile and easily accessible to different patients. That's about $200. And and then the software. So you pay $10,000 and you get 4 devices that you get access with the software. And then we can add other services on if we decide later on we want to do neurology or whatever else. Those could be added on at a later date into the contract, into the system. It's all readily available. It all works the same way. And what's really cool about it is you press the button on the thing. On the iPad or the iPhone, whatever you happen to be using, and it calls a provider. It says you want intensivist services, and it goes through a number of intensivists. So if one of them can't get it, it's going to ring to the next one. It does it like a little daisy chain until it picks through, gets to the person that picks it up, and you're guaranteed to get somebody. And then they answer, and then you have your consult and whatever's going on, and they can access through the EHR through multi-factor verification. They get the labs, they get the x-rays, they get whatever they need to see, and they can see the basic ventilator settings and the vitals of the patient. It's really, really a great system. It's really, really, really easy and not hard for the staff or the provider to use. Rolling stands, like I said, for accessibility. So the patients that, can't hold it in their lap or whatever, or need assistance, we also have that available as well. Another cool thing that I really think is going to be successful once we get this implemented in the hospital is hospital to home. You obviously want to build upon these successes that we have in the hospital. We want to increase the access in the community because the community is farming community. It's spread out. A lot of people have a hard time getting to appointments and whatnot. And that includes our high-risk patients, those patients that have chronic obstructive pulmonary disease, COPD, or congestive heart failure, CHF. Those patients really are high risk to come back in the hospital as a readmission. We get penalized at the hospital from the government for having these readmissions or certain amounts of readmissions. If we do better and we have less readmissions, we get more reimbursement and more money from the government. And that's great for the hospital, but it's also great for our patients because they have improved compliance with their care and they have this improved access when the home health team goes out there and they integrate them into our system and they get to see how they're doing and they meet with a nurse practitioner or physician from the office and they get to really follow up on their care and make sure that they're compliant. And that's what we need. We need them to be compliant and being able to manage their own care. Board member questions and answers. Question 1. The board has received some complaints from long-term physicians regarding the ease of use of the new telemedicine platform. Can you ensure us that we're not investing in technology that is going to be difficult to implement and sustain here at Happy Health? The answer. The official intensivist rollout through project management is next week. We've taken frontline staff and both our older and younger physicians through device orientation with our change management specialists in a project steering committee over the last 2 weeks to test the software. With this feedback, the project manager has made changes to ease the use of the devices through reducing icons on the desktop, enlarging some of the icons, and setting up one-on-one classes with all staff. The overall take-back is that the program is easy to use and will be a great fit at Happy Health. Question 2. Why should the board consider allowing the home health team to implement telemedicine into the community? Well, it will provide a much-needed access to care and follow-up of our high-risk patients with COPD and CHF. These patients, again, have a higher risk of readmission to the hospital. This costs the hospital money and fines associated with government reimbursement. In addition to the aforementioned reasons, telemedicine will improve access to follow-up care and the quality of care provided to the community we serve. Question 3. The board does not want to run into compliance problems with the new telemedicine devices. Has there been a risk assessment completed to ensure that all of our patient population can use the device to access care even if they require assistance? Yes. All of our patients have the appropriate access needed and required when utilizing the new telemedicine devices. A risk assessment was done to test this and make sure that we were in compliance. Here's my references. And thank you very, very much. I really appreciate it. This has been a great class.